Name is Dr. Kannan Kumar and this is Plexus Ortho, and we are going to discuss about physeal injuries and physeal fractures today. Very important topic for both the theory and your clinical exam, right? Uh, so the incidence of physeal fractures is one third of all children's fractures or pediatric fractures is physeal fractures. So children have this unique part of their bone called as physis or growth plate. Okay, this is very different from adults, and they are able to grow the bone because of this physis. There is both longitudinal growth as well as oppositional or girth wise it grows. Oppositional growth is also present, right? The peak incidence of these fractures in girls is about 9 to 12 years of age, and boys is 12 to 15 years of age. Now let's go back to the anatomy, right, of a long bone. Right, we have the shaft of the long bone here. You have the metaphysis, you have the epiphysis towards the joint, and in between the epiphysis and metaphysis is called the physis or the growth plate. Right, the growth plate has a unique histology, and the child is able to correct its deformities in the plane, the maximum in the plane of the maximum movement. For example, in the wrist it would be the sagittal plane or plane of wrist and wrist dorsi and palmar flexion. So growth plate helps us in correcting deformities after an injury, helps in the longitudinal growth of the bone. So growth plate or physis lies between the metaphysis and the epiphysis. This is a very important concept that we must all understand. Coming to the physeal anatomy, this has been asked very frequently in your theory exams. This is about a 10-mark question, so you must know it in great detail, right? There are multiple zones. The first zone, that is towards the epiphysis, that is towards the joint. E for elephant, epiphysis is here is the epiphysis. A is the epiphyseal bone. Next, this is the actual growth plate from B to E. So the first layer that we see is called as a reserve zone. What is it called? It is called as a reserve zone. These contain cells that store lipids, glycogen and proteoglycan, and they produce matrix later on, and they have low oxygen tension. Right, so basically, as the name suggests, reserve zone, it is where from here the cells begin their journey towards forming of bone, right? And it contains cells which stores a lot of important material for future growth of or making of the bone. The diseases that can occur in this area include Gaucher's disease, very important, diastrophic dysplasia or DD for short, diastrophic dysplasia, Nice disease, and pseudoachondroplasia. Right, one thing you must remember is in the resting zone is where you have pseudoachondroplasia, whereas in the proliferative zone is where you get achondroplasia. Right, in the resting zone you get pseudoachondroplasia. In the proliferative zone, the disease that occurs is the achondroplasia. So the next layer or C is the proliferative zone. Here the chondrocytes start to begin to proliferate with longitudinal growth. You can see that the chondrocytes are growing longitudinally, and there is a stacking of the chondrocytes. You can see the stacking of the chondrocytes, which is very clear here. And here there is a highest extracellular matrix production. There is increased oxygen tension, highest extracellular matrix production, increased oxygen tension in the surrounding areas. The diseases that can occur here are achondroplasia, gigantism, that is excessive growth of the area, or multiple hereditary exostosis. These are the things that can occur in this layer, that is the proliferative zone or zone C, that is marked here. The next zone is called the hypertrophic zone, where the chondrocyte maturation, chondrocyte hypertrophy, and chondrocyte calcification occur. So they are divided into three parts: maturation, degeneration, and provisional zone of calcification. So zone of maturation, zone of degeneration, and provisional calcification. So in the zone of maturation, there is preparation of matrix for calcification, right? In degeneration, further preparation of matrix occurs. Further growth of the chondrocyte up to 5 times can occur. And in the provisional zone of calcification, the chondrocyte undergoes death. The chondrocyte dies, allowing calcium release, and calcification of the matrix occurs in this zone. Here you also have what is called as a type 10 collagen is seen, or type 10 collagen is produced by hypertrophic chondrocytes for mineralization. So this is an MCQ question which is very commonly asked both in your NEET PG as well as in your future super specialty MRCS and FRCS exams, which you can remember. The next zone is the primary spongiosa zone, right? Primary spongiosa is where the vessels start invading, the blood vessels start invading and vascular invasion and resorption of the transverse septae occur. The osteoblasts start forming and align on cartilage bars produced by Physeal expansion. So this is the primary spongiosa. Then comes below this comes towards the metaphysis is the secondary spongiosa. Secondary spongiosa is where the bone gets remodeled and actually becomes the bone that we see in adults, or the bone that we see in the metaphysis and the shaft. This is called as secondary spongiosa. So to recap, this is the epiphysis zone A. Zone B is the resting zone, right? Zone B is the resting zone. Zone C is the proliferative zone. Zone D is the hypertrophic zone. And in this zone is further divided into 3 parts: zone of maturation, degeneration, and provisional calcification. This is followed by primary and secondary spongiosas. So this is in brief about the Physeal anatomy, which is very, very important for your exams, both in your theory and in your practical Viva OC and OSCE as well, right? In the physis and epiphyseal region, one is the groove of Ranvier. Okay, during the first year of life, the zone spreads over the adjacent metaphysis to form a fibrous circumferential ring bridging from the epiphysis to the diaphysis. So this is called as a groove of Ranvier, where there is a groove formed over here. It is called the groove of Ranvier. This ring increases the mechanical strength and prevents as much as possible physeal injuries. So this has to give way for physeal injuries to occur. What are some of the characteristics of the physis? It is weaker than bone in shear strength. Shearing is when this is the metaphysis, this is the physis, this is the epiphysis. When there is something which is separating these two apart, it is very weak. It is very weaker than bone in shear strength and stronger than bone in compression, right? So when there is compression like this, top here and here, it is stronger than bone in compression, and a lot of factors play a role in physeal growth and its physiology, including thyroxine, estrogen, and growth hormone. All of them play a very significant role. Now we can see this another picture of this. This is called the perichondrial artery, which supplies the physis and gives its blood supply, because it does not have its own vessels, and the first blood vessels start appearing in the primary spongiosa and the secondary spongiosa. Now the weakest point is the hypertrophic zone and probably the zone of calcification. Zone of hypertrophy. Injuries can occur because of various forces: crush injury, shear, avulsion, repetitive injury. For example, like gymnasts or athletes or ballet dancers, these people can have repetitive injuries. Indirect injuries or insults can occur via vascular or iatrogenic problem. Physeal fracture patterns, there are many classifications. I don't think you need to remember all these classifications. Just to simplify your exam, the most common classification and the best, probably the best classification is the Salter and Harris classification. Right? So coming to Salter and Harris, all of us know there are 5 types of Salter and Harris classification. The type 1 is where the injury occurs completely through the physis and this usually occurs through the hypertrophic zone, right? This is a Saltram-Harris type 1. And Saltram-Harris type 2, which is the most common type of physeal injury, the injury occurs through the physis and the fracture line exits through the metaphysis, leaving a fragment of the metaphysis attached to the part of the physis and epiphysis. So this is called as a Thurston. What is it called as a Thurston-Holland fragment? Thurston-Holland fracture or Thurston-Holland fragment. So this is the most common variety of physeal injury. Saltram-Harris type 3 is the fracture passes through the physis and there is a fracture line exiting through the epiphysis. So this is the Saltram-Harris type 3. In Saltram-Harris type 4, it is a through and through fracture starting from the epiphysis and exiting the metaphysis, passing through the physeal area. This is Saltram-Harris type 4. And all of us know about Saltram-Harris type 5, which is a type of crushing injury. There is a crushing of the physis between the epiphysis and metaphysis, and this can only be seen at a later date, right? When the crushing occurs, actually it's very difficult to make out in radiographs, and over a period of time when physeal bar happens and a damage to the physis happens, you can see it in the later radiographs. What are the sequelae of physeal injuries? If the physis is damaged, bone growth can occur through and through. Bone can cross over from the epiphysis, from the metaphysis to the epiphysis, causing a bone bar, or there can be reduced growth in the because of the growth plate disturbance, and it can cause a leg length discrepancy or a limb discrepancy in the upper limb. If only a part of the physis is damaged, it can cause an angular deformity, causing what is called as a physeal bar, where the bone is bridged between the epiphysis and metaphysis. The bone is bridged between the epiphysis and metaphysis. So these are some of the sequelae of physeal injuries. And what can happen in the long term? You can have degenerative arthritis because of a step in the intra-articular portion. You can have avascular necrosis because of a lack of blood supply. You can have non-union, for example, in the medial malleolus. The most common areas of physeal arrest include the distal femur, proximal tibia. Distal tibia can also happen in the distal radius as well. The most common pattern is type 3 and 4. What is type 3 and 4? We just now described it. So this is the physis. Type 3 is where the fracture line passes through the physis and through the intra-articular portion, and type 4 is the fracture line passes through and through from the epiphysis to the metaphysis. Usually it is a very high energy trauma for the femur fractures and other major bones. However, in the ankle it could be a low energy or a twisting injury. Physeal fractures heal very well. They heal within 3 to 4 weeks. Usually if you can't do close reduction in 2 weeks, it is better not to attempt close reduction, because callus formation occurs and it provides poor results. The ankle physeal in the treatment guidelines are basically you have to restore anatomy. Anatomy should be restored. It doesn't matter what you do. In ankle Saltram-Harris type 3 and 4, you have to restore anatomy and make sure there is no intra-articular step. In knee, any displaced fracture of the distal femur should be done. In the elbow, intra-articular fractures and multiply injured injuries, you should also take it up for internal fixation and accurate reduction. So for example, this patient has a 13-year-old male with a twisted ankle, right? You can see the physeal injury passing through the medial malleolus, and this is probably a Saltram-Harris type 2 because the fracture is passing through the physis and then passing through the connecting to the epiphysis. This is fixed anatomically with the help of a screw. And when we did an X-ray at 6 months, it showed a damage to the physis at the lateral area, and it was not growing as well as the medial side or the opposite side, and the angle was 80 degrees on the affected side as compared to 90 degrees on the unaffected side. And when we did a CT scan, this is the physeal bar. There is a bone connecting between the metaphysis and the epiphysis. So we went ahead and we excised the physeal bar here, filled it up with adipose fat and tissue here, and we have put markers, K-wire markers to monitor the growth of the bone and to make sure the deformity is not occurring again. And when you can see in 6 months, it looks like they are parallel to each other with good adequate growth of the bone and correction of the angle as well. Another example of a distal femur fracture. epiphyseal injury, probably a type 2, which is the most common variety here. And the patient went on to have quite a big deformity, if you can see on the right side as compared to the left side, indicating a physeal arrest on the lateral portion of the physis of the distal femur. There's another thing that you can see on X-rays. It is called as growth lines, growth arrest line. For example, if the patient has sustained a fracture over a period of time, as it heals, you can see some radio opaque lines. These are called growth arrest lines. But if there is a angular deformity, or if there is a physeal bar in one location, there is an angulation of the growth arrest line. This indicates that the patient is probably going to have a deformity at a later date. So you must have what is called as a symmetric growth arrest line, which is a good prognostic sign for physeal injuries. Now finally, let us take up an example of a case here. So all of us know that the ulnar variance is either plus or minus 2 millimeters. So if you can see here, the ulnar variance seems quite significant, maybe up to 10 millimeters. Why has this happened? So this patient is a 13-year-old boy who had a distal radius fractures who were fixed with K wires about 8 years ago. And unfortunately, there is a big physeal bar we can see here, and has caused growth restriction of the radius. Now in this case, because of growth restriction and unrestricted growth of the normal growth of the ulna has become longer and the radius has become shorter. And also there is a dorsal tilt. Normal is volar tilt of 10 degrees, and as you can see, there is probably a physeal damage on the dorsal side, and therefore there is a dorsal tilt. So these are the two problems. So what will you do for this patient? Ideally, for this patient to restore length, we have to shorten the ulna, followed by correction of the deformity of the radius. So this will restore the balance of length between these two bones and will cause normal appearing wrist. Although it may be shorter than the forearm, may be shorter than the opposite side, it will appear to be normal. We also have to do an epiphysiodesis of the ulna to prevent further growth. Since the child is about 13 years, about 4 years of growth left, and doing an epiphysiodesis of the ulna will prevent further lengthening of the ulna as compared to the radius. So this has to be done for this patient to correct the deformity. So with that, we come to an end of regarding physeal injuries. Hope you had a brief understanding of this and can approach this in your exams in a objective way. Thank you very much.